January 27th, Sean Carroll, who used to be with the UW-Madison in the Laboratory of Genetics, and who's long been with the Howard Hughes Medical Institute, will be here to talk about his new book called A Series of Fortunate Events, Chance and the Making of the Planet, Life, and You. So that's really grateful that Sean would be willing to give the talk. So those are the 3 talks for the rest of January. And I'll start the little more formal introduction and welcome everybody to Wednesday night at the lab. I'm Tom Zinnan. I work here at the UW-Madison Biotech Center. I also work for the Division of Extension in Wisconsin 4-H. And on behalf of those folks and our other co-organizers, PBS Wisconsin, the Wisconsin Alumni Association, and the UW-Madison Science Alliance, thanks again for coming to Wednesday night at the lab. We do this every Wednesday night by Zoom, 50 times a year. If you were tuning in to hopefully to hear Carrie Kuhn's talk, I have to again let you know that she's unfortunately had to postpone her talk. And in her place, I'm delighted to be able to introduce Pat Remington. He's going to talk with us about COVID-19, the pandemic, public health, and politics. Pat, I get to ask you the 5 questions now. First, where were you born?
I was born at St. Mary's Hospital in Madison, Wisconsin.
Way to go. Where did you go to high school?
I went to Madison West.
Way to go. And where'd you go for your undergrad?
UW-Madison.
What'd you study?
I studied molecular biology, but I was in the honors program, and my major professor was Tom Brock. And so I did a bit more bacteriology as my focus. And I'll talk about that actually in a few moments.
That would be great. Were you involved with any of the Thermus aquaticus work?
I was.
Oh, you have to come back and talk about Thermus aquaticus.
Well, I was an undergrad. I was 20 years old, and I knew very little about what I was actually doing out in West Yellowstone. But it was wonderful having a mentor like Tom Brock, and looking back, just humbled by the experience.
Outstanding. And then where'd you go for your medical degree?
I stayed right here at the UW and went to the UW Medical School.
And then you also have a master's of public health?
I do. I went to the University of Minnesota, their School of Public Health in the Division of Epidemiology. I got my Master of Public Health in Epi.
And you were associated with the Center for Disease Control?
I did a 2-year fellowship called the Epidemic Intelligence Service. And again, I'll talk about this in a moment. And then I stayed on to do a preventive medicine residency. So I'm board certified in preventive medicine.
Thank you very much. And then you were associate dean for
10 years to the day. I retired from that position in July of 2019.
And that was the Department of Public Health Sciences.
Yeah, Department of Population Health Sciences.
Sorry.
I could talk about why it's not public health and called population health. There's a whole backstory behind that, but we call ourselves Population Health Sciences, although I consider myself really a public health professional.
But the school is the School of Medicine and Public Health, is that correct?
Yep.
Okay, great. All right, and I'm delighted that you're going to share with us your insights into COVID-19. I'm very grateful to have you here tonight, and you can go ahead anytime you'd like. Thank you.
Well, thanks, Tom. Thanks for the invitation, and I'm pleased to be back. This is actually the second time that I've been at the lab as a speaker, and it was some time ago that I talked about my work in public health surveillance. But what I'd like to begin with talking about today, and give me a moment because I have to get into the. I'm going to have to stop sharing because I have to open up PowerPoint and make sure that I can actually and show. I apologize for this. So let me go back to here. I will share screen, and there's PowerPoint. Okay, can you all see that?
Yes.
Yep, and then if you can make it so that it's the big view, that'd be great. Thank you.
I will. Okay. Well, let me just begin by obviously talking about the situation in our country. As we speak, I've been riveted listening to National Public Radio, reading the newspaper and different social media accounts, and it's absolutely, a tragedy. It seems to me to talk about what I thought was one of the most important problems facing us today, the global COVID-19 pandemic. Then suddenly this morning I realized that there are other pressing issues. But I actually think that there's a connection between what's going on in Washington, D.C., and our nation's capital today, and some of the politics in the response to the COVID-19 pandemic. And I'll talk about that, because I think sort of my take-home message is that COVID-19 may have surprised some people, but for those of us in public health, particularly infectious disease epidemiologists, it's not been a question of if this would occur, it's been a question of just when. And this has been on the horizon for decades. Global pandemic preparedness has been something CDC's done for many years. But what I think has been surprising is the response of the public and our policymakers. And I don't think anybody really anticipated that. I think that's something that we've realized with this pandemic. It's almost been a stress test or a diagnostic test for our nation about how prepared we are to confront significant public health problems. So I just want to put this into the context. And again, we'll understand if you've got another window opening up following the affairs in Washington as they unfold. The other thing I want to say is I'm not Anthony Fauci, and there are, I aspire to be Dr. Fauci, but he is an amazing leader. He's, obviously the single best spokesperson for this pandemic. And if you really want to hear about it, you could, I'm not serious, but, hang up now and dial in on January 7th. He's been, this is the different UW, Washington University has been fortunate to get him to come and speak tomorrow, actually. And also, I just want to recognize the team of physicians at the State Lab of Hygiene, the State Health Department, and our School of Medicine and Public Health. I am really an amateur in this whole area of COVID-19. I am not a frontline clinician. I am not an expert in infectious diseases. I'm not a laboratorian. I'm not a virologist. So I really would say that if I have anything, it's a sort of an inch deep, but maybe a mile wide in my expertise in public health and in infectious disease epidemiology. So I just am humbled to be in the presence in this past year to see people like Al Bateman and Ryan Westergaard and John Myman and others at the State Health Department who are, truly leading our state's response. So I'd like to talk about 5 things this evening. First, I think it's always interesting to understand when somebody's speaking, of what path they took to be able to talk about a subject like COVID-19. So I'll briefly review my path, and it'll be a bit of repetition to Tom's 5 questions. Then I'll briefly talk about the epidemiology of COVID-19. Again, some of this may be repeat information for many of you who follow this issue closely. And then I'll talk about really the meat of my talk, which is the public health response and particularly the politics related to the pandemic. And then finish by opening up a discussion about what comes next. So as I mentioned, I came to the UW in 1972 from Madison West. I picked molecular biology as a major, and I was interested in going to medical school. And in doing so, I took all the pre-med courses, but I also had the good fortune of working in a lab. And I'll confess here publicly that it's not so much what you know as an undergraduate, but who you know. And Professor Tom Brock was my next door neighbor, lived across the street, and I'd known him growing up. And so when he found out that I was interested in science, he offered me a position in his lab. And in doing so, I was incredibly fortunate to join the Laboratory of Thermonuclear Biology. I actually not only worked in his lab in Madison, but I spent a summer of 1974, working out in West Yellowstone in his 2 or 3 trailers where he did research on the hot springs. And this was an amazing an opportunity for me as an undergraduate, and really taught me the importance of basic science, of really understanding the fundamental science and the biology of organisms. I decided, though, rather than pursuing a career in basic science and in bacteriology, which I'm sure disappointed Tom at the time, I decided to continue on to medical school. The picture shows the old medical school, which is where I began my medical training. I was interested in the time in primary care, but I also had an interest in global health or working in an underserved community. So upon my graduation, or my 4th year, I should say, I had planned an elective in Zaire, just outside of Kinshasa. And unfortunately, in December of 1980, there was civil unrest in that country, and we got a telegram. My advisor, I've been talking to Sandy Rotter about this. Ned Wallace was my advisor, and he sent me a note or maybe a phone call. There was no email back then, but said that unfortunately my elective rotation in Africa was canceled, and I needed to scramble at the last minute to find something to finish my medical school training. And I found a 4-week elective at the Wisconsin Division of Public Health. And I would have to say that elective certainly changed my life as a student. I learned about epidemiology. I learned about infectious disease epidemiology. In fact, when I started work on a Monday morning, there were slips of paper about some individuals in southeast Wisconsin who had developed this unusual lymphadenopathy, nodes on the arm that was looked like sporotrichosis, which is a fungal infection that happens, and in this case, it happened to people who were working with sphagnum moss, pine needles, and building gravesite decorations. And I just, I went down there, I interviewed people, I looked at whether they wore gloves or didn't wear gloves, their age, where the moss came from. We traced it to central Wisconsin, where sphagnum moss, I guess, we're one of the major manufacturers of sphagnum moss in the country. And sure enough, some of these Sporotrichium schenkii spores had found their way into this moss and then injected with these needles into the skin of these workers. And to me, that just lit a light bulb. I said, this is actually a job. This is something people can do for a living, do epidemiologic investigations. And so I had the good luck to have my advisor in medical school was Dennis Mackey. And I met with him in my 4th year, told him about my interest in that elective and my interest in working overseas. And he said, basically, and I'm sure he had a T on the end of want, but he said, if you want to work in public health, then you need to learn epidemiology and public health. And he counseled me. Actually, I take that back. He picked up the telephone and called CDC and said, I have a student in my office who should work at CDC. And I didn't know at the time, he was talking to another former UW grad, a guy named Phil Brockman, who was the director of the Epidemic Intelligence Service. And so again, a bit of who you know. I had the good fortune of knowing Dennis Mackey, and he put me on a track to apply to the CDC. And again, this was with very little experience in public health, 4-week elective, and I had no epidemiologic training, no public health training. I simply was, getting my medical degree. And again, I had the good fortune of being admitted into the program. Learned that in actually on Christmas Day of during my internship, because I had to make some decisions, and the head of the CDC program called me on Christmas Day. I actually called my wife and told her to get a hold of me. She said, "You know, it's Christmas Day," and he said, "Yes, but I think he'd like to hear this news on Christmas Day." And so I went to Atlanta, and that really changed my life. In fact, I like to show this graphic. This is sort of, when you come to a fork in the road, take it. And for me, this was a bit of a diversion of my medical training. When I went to work at CDC, I was assigned to the state of Michigan as an epidemic intelligence service officer. I was in the U.S. Commissioned Corps as a public health service officer. And I worked on public health, and I stopped seeing patients. I thought for sure I would come back to finish my clinical training once I achieved my training in public health and epidemiology, and didn't know at the time that would not occur. So beginning really from my last day as an intern in Seattle, I no longer practice medicine. And that internship was really riveting for me because I started at a children's hospital, did 2 months of intensive care work as an intern in the children's hospital. And I took care of very sick kids who were often injured by preventable injuries, near drowning, automobile accidents, falls, burns. And I just kept asking myself, working hard to save these kids and to do the best we could. But I just found myself, my mind was wondering, why did this have to happen? Why this really tragedy for these parents to deal with? And then I went over to Virginia Mason Hospital, and actually it was harder for me because I was dealing with cancer patients and cardiovascular disease and alcohol-related disease. And, there was relatively little we could offer, maybe prolong a clinical course, but very few people recovered. And that really cemented my interest. That, along with my short experience in what public health was, by halfway through my internship, I was convinced that I wanted a career in public health to focus, as we say, upstream on ways to improve the conditions in which people live or work or play, so that they don't end up like this child or this man at the end of their life needing life-saving care. And so I went to CDC, and again, as I said, I joined this epidemic intelligence service. I knew very little about it, and since there's been a movie actually about it, so it turns out I played the role of Kate Winslet, or I should say Kate Winslet played the role of me as an epidemic intelligence service officer. And by the way, go back and watch this movie if you want to know how prescient the writers of this book and the producers of the film were. This looks frighteningly similar to what is actually transpired. So I spent, again, I thought I was going to be there for 2 years. I ended up being there in total for 6 years. And during that time, I worked on a lot of different public health problems: Rye syndrome, foodborne outbreaks, airborne measles outbreak, looked at trends in smoking, chronic disease prevention. We started this surveillance system of health risk behaviors called the Behavioral Risk Factor Surveillance System. But I think looking back, it's probably my work on an airborne measles outbreak that I think of as being really novel, what we call shoe leather epidemiology, where I use the power of observation to investigate an outbreak and to learn something about the biology and epidemiology of measles. And one day I got a call from a physician, it was a physician working in Muskegon, Michigan, who said that a very strange thing had happened, that he had seen a patient with measles in his office, a baby who had been adopted from Korea, and he diagnosed respiratory illness, which was subsequently diagnosed as being measles. And so he quickly admitted that patient, and that patient left the doctor's office. And children who came in after that patient departed subsequently developed measles. And this is a picture of that case. So the index case, who had measles and was quite ill, came into the office at 11 a.m. and was admitted to the hospital at 12:30. Left the doctor's office, walked across the street, and it was admitted to the hospital, was very sick. And 4 children came into the doctor's office starting at 12:30, but then 3 children notably came in an hour and a half to 2 hours later. And all those 4 children developed measles. And this demonstrated, and I think I even drew a map of where the index patient, number 1, went, sat in the waiting room and the room. And you can see from this, cases 2, 3, 4, and 5 didn't sit in the same chair and weren't in the same examination room. So there was very little probability of what we call fomite transmission, touching the virus with your hands. No possibility for at least 3 of the cases of direct contact. So this was really good evidence that measles can be suspended in the air. In fact, I developed a model. I had to call my calculus teacher from UW and ask how to integrate the area under a curve. I once knew that, but I forgot it quickly. And I generated a model. I created a model that said if patient 1 arrived at a certain time and there was a dilution, air exchange rate of dilution, how much virus would they have to be putting out into the air at what? Oops, I accidentally muted myself there. How much virus would they have to put into the air so that this patient who came in at 145 got at least 1 quanta of infectious material? And what we determined is that this index patient was putting millions of viral particles in the air. And later, this phenomenon has been called super spreader, that this young patient, for some reason, was putting a tremendous amount of virus into the air, so much that it was airborne, and that although when the patient departed, it began to be diluted, there was enough virus present 2 hours later to infect 3 patients. And so this is really a good example of shoe leather epidemiology. And by the way, this is a very important question for COVID-19, for SARS-CoV-2, which is the question, is it transmitted by direct air droplet spread, or could it be spread by airborne spread? And I'll get back to that question in a moment. No, so now all of a sudden, it's not allowing me to advance this, so I'm going to escape. Are you able to hear me, Jane? You're the only one I can see. Can you give me a thumbs up if you're hearing me? I see or not.
I can hear you,
Okay.
Pat.
Yeah, so I'm going to just stop sharing and go back into my PowerPoint and just reload and go back into Zoom. Not sure why that happens. And share again. Might have touched something wrong. Okay, and then I'm going to go into presentation mode. There.
I always blame it on the application.
Yeah,
not the user.
the app. So following that, my paper was published in JAMA, and it was a pretty important paper demonstrating that measles was not only highly contagious, but most certainly spread by airborne spread. And then this was a kind of a recommendation, a public health recommendation. You know, when the patient with measles or suspected measles, why don't you just throw open the windows, improve air ventilation? And this actually comes back to a question about, you know, how I get this question often on COVID-19, how do I reduce my risk? Well, stay outside, or if you go inside, make sure you have fresh air ventilation and maybe windows and doors open. Well, I'll fast forward then from that 6 years of my career to spending almost 10 years at the Wisconsin Department of Health Services in the Division of Public Health. That was where my office was, on the second floor, overlooking at the time Lake Monona. Monona Terrace was there. And then I served as a faculty member in the Department of what began preventive medicine and became population health sciences for 22 years, and the last 10 as associate dean. Oh boy, no. Okay. So, and then I retired in 2019, but I failed that test by coming back part-time. I'm a rehired annuitant. I am working, teaching, running a residency program, and spending a lot of time talking about COVID-19. So let me just switch gears and talk about this global pandemic, which, by the way, I mark almost a year ago when I began a course I teach to undergraduates on public health. I said in that first lecture that a virus has appeared in China and may well turn out to be a global pandemic. I was engaging in hyperbole because we've heard that a lot, and I did not think that it would actually come true. We've learned a lot about the biology, and it's amazing that a year ago nobody was talking about coronaviruses and spike proteins and RNA viruses and RNA vaccines. And here we are now understanding that all the work that virologists have done turns out to be incredibly important. So this is a coronavirus, and I think the important thing to know about it is that it's just brilliantly designed to wreak havoc in humans. The virus can get into the respiratory system, can latch on to receptors in cells, inject the RNA, their nuclear material, and then hijack the industry of each cell, and then allow that cell to replicate the virus, and then effectively killing that cell and spewing out hundreds, maybe thousands more copies of the virus. So incredibly efficient machine for infecting cells, killing cells, and spreading. This isn't the first coronavirus. There are 4 types that cause the common cold. Maybe 15 or 20% of common colds are caused by coronaviruses. So they've been around for a long time. And you may have heard about MERS and SARS. These are actually highly contagious and very serious illnesses with 20, 30, 40% case fatality rates. The difference is in their clinical syndrome, they are easier to diagnose and they don't become infectious until symptoms develop. So traditional public health approaches work to contain these outbreaks, and the novel coronavirus, SARS-CoV-2, does not have that characteristic. And again, this is a timeline showing from really the end of 2019 until the last day of February. This infection exploded worldwide. Began obviously in Wuhan, China, but we had our first death. First case in Wisconsin was first case was diagnosed, I believe, in February. And then the first death at the end of February in the US. And I talked about the transmission and the important difference between droplet and airborne transmission. And we have treated COVID-19 as a droplet transmission disease. And that means stay 6 feet away, stay outdoors, reduce the likelihood that these large droplets containing the virus will get onto your mucosa or you breathe in. I think there's good evidence that this virus can be transmitted by airborne transmission, but I think the evidence is that it's not an important mechanism of transmission. If it were, we would see large outbreaks in entire buildings where hundreds or maybe thousands of people are infected, or in airplanes. And what we see generally is a pattern that the closer you are to the infected person, the higher your risk. There is evidence of people getting infected from quite a distance. And so we think airborne transmission is possible, but again, fortunately, it's not a major source of transmission. What are the symptoms? Well, it depends. It depends on your age, and it depends on probably on the dose of virus that you're exposed to. But it can range from no symptoms whatsoever to severe respiratory distress requiring mechanical ventilation and even death. So it virtually attacks every organ of the body. Begins obviously in the respiratory tract, but is considered a sort of a system-wide infection. So, and you've heard this debate, maybe even from our Senator Ron Johnson has said that it's not that serious, only 1% of people die. Well, I have two things to say about that. One is 1% overall, but look here at what we call the case fatality rates. As you get into your 50s and 60s, the percent of people who die goes up to as high as 10% for those in their 75 to 84, or 25% for those over the age of 85. And a recent study that just was published showed that from April to June to August, these case fatality rates have persisted. We really haven't done a very good job in improving treatments for people once infected. So again, those numbers are important, that if you're under the age of 20, it's very rare, maybe 1 in 1,000 might die. But if you're in your 70s or 80s, that's an extremely high case fatality rate. That means that 1 in 4 or 1 in 3 people infected at that age will pass away. And therein lies the strategy for control measures to keep seniors, older people safe, particularly those in nursing home or long-term care facilities, and to administer the vaccine to those individuals as a top priority. So let me then shift gears to talk about what are the current trends. I gave this talk, and the reason, I'd say, Tom, the only reason I could respond, was it last night or 2 nights ago, affirmatively, was that I talked to a group of faculty September 8th. And so this is now 4 months since that time. So what I've done is I took the slides that I prepared for September 8th and I've just updated them. And back in September, this is what the world looked like. These were the hotspots. Interestingly, South America at that time was a hotspot. So was Spain. And you can see parts of Europe, France, and the United States was in the higher category. And now look what this is the same map as of yesterday. And you can see the dramatic increase in the US and in some European countries, particularly England and Sweden. So these have become by far the highest risk places in the world. And again, one thing I want to caution people, sometimes you see maps which show numbers of cases. I think it's critically important to always look at rates. They sometimes call it per capita. So these are average daily cases per 100,000 in the past week. And again, the US is far and away one of the hottest spots in the world. This is what the map looked like in September when I talked. There weren't enough cases to show risk in rural areas, and the southeastern states were highest. This is per capita. I believe this is death rates, and you see those hotspots. And now you go to today, and notice it's shifted to the upper Midwest, and just the change in color and intensity. So this has gone from an outbreak that happened in Seattle and New York to one that spread to the south very quickly, but then exploded to the rest of the nation, particularly the upper Midwest. So that's a tremendous change. What about in Wisconsin? This was the map at that time. A few counties in the central part of the state and the north. These are, again, the hot spots. And then what does it look like today, January 5th? Tremendous increase. And look at the average cases per 100,000. So this was, the hotspots back then were in the 50s. And now the hotspots are 5 times higher than that, 100 or 250. So tremendous spread throughout the state. And I would argue that there aren't really any hotspots. I mean, that I think is Juneau County, Menominee County, maybe Trempealeau, Fond du Lac. Those aren't really the hottest places. Those are just happen to be in the last week to have a few more cases. There isn't a place, there is no county spared in the state of Wisconsin that hasn't been affected by this outbreak. And this is a really interesting perspective. This is sort of, this was what I was thinking about, and when I gave this talk in the middle of September, I said, well, here's what happened. We had a increase in April, and then a bit of a decline, and then a bit of decline in mid-May, and then some real progress in mid-June, but then a very big increase to the middle of July, and we're on the right track. But I noticed a little bit of a ticking up, and this is what that trend looks like. That's the map up until the middle of September, or the graph up until and the reason I made it that size is this is what has happened since. So this is in the 4 months since I gave that talk in September. There's no way that I anticipated that kind of tremendous outbreak. Look at that, there's 8,000 cases in one day, almost 8,000 cases in one day in the middle of November. So unbelievable transmission. Beginning in the middle of September, and hopefully that peak will never be seen again. But look now at what's happened since the end of 2020. We are now seeing a resurgence, and so who knows? I'll talk a bit about that at the end, but who knows whether this, I'm going to have to, 4 months from now, flatten that to show what really happened when we got to 10 or 20,000 cases per day. But hopefully we've seen the worst of the pandemic in the state. This is trends in deaths up until the middle of September. And you can see that we're averaging about 6 or 8 deaths per day. And then this is what's happened since. We've had as many as 120 deaths per day. Averages went up to 50 to 60 deaths per day. And so tremendous increase beginning in the fall to become one of the leading causes of death. Again, this was what we were looking at back in September. The total number of deaths, we just broke 1,000, and people were really shocked by that. Well, this is the number from today. Today, we broke 5,000 deaths. And just, pause for a moment and think about 5,000 people. That has become the 3rd leading cause of death in the state of Wisconsin, behind only heart disease and cancer. It is a phenomenal number of people dying from a single cause. And nobody saw this number of deaths coming. And I'll come back to that. And then on the UW campus, we were monitoring trends in testing and the 7-day average. And you could see that we were seeing quite a few cases. So that on the UW campus by the middle of September. Well, if I move that graph into the right perspective, we then in September saw an outbreak on the UW-Madison campus. It was primarily in Greek housing, some off campus, but also in the dormitories. And in the dorms, there are really 2 or 3 dorms known affectionately by people working in this on this problem as the party dorms. And so that, fortunately, control measures were implemented. People were put into quarantine and isolation, and you can see that reduced to low levels in October, increasing a little bit in November, but we're really back down to, I would say, a very controlled situation on the UW-Madison campus. Again, we will see what happens when students, some of whom will come back in January. But I would say that this was a surprising outbreak in September, more than some people thought, although other people would say it was entirely predictable, and a bit of a resurgence in November, but not as much as some people feared. So let me then shift to the final question is, what do we do about the global pandemic? Well, these are the 5 sort of strategies to address a global pandemic. One is you just lock down, shelter in place. And in fact, it's been said if we could do that with 100% of the population, the virus would cease being transmitted. It would run through the cycle in households in 2 or 3 weeks, and it would no longer be circulating. And the problem is we just can't do that. Some people can, but many people cannot shelter in place and socially isolate. Second, we have societal measures like quarantine and isolation used by public health, social distancing, wearing masks, hand hygiene. We have the public health response, which is the testing, tracking, and tracing. And then obviously, should those approaches fail, we have treatments, drugs, and other therapeutics. And then finally, to prevent the disease, we are on the precipice of having vaccine for everybody. What's been the response to these strategies? Well, I love Jack Nicholson. Some of you may know this movie, but its caption is "A couple of weeks isolation with the family. What could go wrong?" Isolation, obviously, or self-isolation and sheltering in place causes a lot of stress and anxiety. What we've learned is, and again, this relates back to what we're seeing happening in Washington today, Washington, D.C., is we've discovered there are fundamental disagreements about the role of law, particularly public health law. So we've seen in our state, but really across the country, people going to court challenging the ability of a public health officer to implement laws or rules or regulations to address an epidemic or a pandemic. Right here in Wisconsin, our Supreme Court struck down the state's stay-at-home order and really hampered our public health department's ability to respond. And I think when you see that, you think, this would be an interesting constitutional law question, but to play this out in the midst of a pandemic, in my opinion, is the wrong time to be arguing about what a governor or a state health officer's right is. Let's address the pandemic and then figure out how to make the laws respond to what people want. Second is we've seen sharp contrast in responses to the public health recommendation. And this again talks about the doubts about the science and issues of personal freedom and personal liberty. Not understanding the nuance that wearing a mask is not simply about protecting yourself, it's about protecting others. But this has been a very divisive issue. And many of you probably have your own stories of arguments, maybe within your network of friends or family, or you've been out traveling when you've seen people who have strong feelings either in favor of or opposed to the use of masks. And again, I think that behavior represents really an expression of one's understanding of the science, but also willingness to protect themselves and to protect others. Third is that traditional public health measures are being challenged. I mean, this is an extreme example. A couple was infected and they were asked to isolate and they refused. So they actually had to be arrested. Turns out public health law allows this. You never want to resort to the use of force when implementing public health measures like quarantine and isolation. But when the response is like this, sometimes you're left with no choice. The other issue is that we really have diagnosed how poorly funded and supported our public health systems are. This is decades of decreases in funding for core public health responses, not just infectious disease, but environmental health issues and chronic disease prevention. And we are seeing the effects of that, of those policies, reducing to bare bones our staff at the state and local health departments. And this headline that came yesterday, bizarre, disorganized, Wisconsin behind most Midwest states on COVID-19 vaccinations. Some workers say they're in the dark. Well, I like to think you get what you pay for. And if you don't support public health at times that are outside of a pandemic situation, then this is what you will expect to happen during a pandemic. So it's not surprising to people working in the system that it's overtaxed. Really, expectations far exceed our public health system's ability to respond. They're doing all they can to respond to the epidemic, let alone now having to muster all the troops to put out an organized vaccine campaign. So again, you get what you pay for. We've underfunded public health for decades, and now we're paying the price. Fifth, the pandemic has really pointed out something many of you, I'm sure, are aware of, but many people are not aware of what fundamental underlying racial disparities that we have in health, but also how this pandemic has affected Black and American Indian populations, Hispanic populations more than whites. And this relates to a number of complex issues, but relates to being in the essential workforce, living in crowded places, not having access to healthcare or health information. So this is really a diagnosis or a stress test that shows that we have underlying racial and ethnic disparities. The other aspect is some people of higher education, you can see on the left, were working 30 to 35 hours a week, a little bit at home, but mostly at work. And look what's happened by late March. This is just late March. People with less education, much lower working rates, so much more unemployment, but also they're having to go to the workplace. Very few people with less education can afford to work at home. And look at the chart on the far right. People with more education, relatively little drop in total employment. It went from 34, 35 to 31 hours on average, and people are managing to work at home. So this has affected people of social and economic differences, people who are part of the essential workforce. They can't work at home, and many of them can't work at all. The hospitality industry has been devastated, so people working in that are finding themselves unemployed. So tremendous differences, not just by race and ethnicity, but by social and economic backgrounds. So let me then conclude by talking about what comes next. I rarely make predictions, but I guess I said in a paper in November that there would be 5,000 deaths by year's end. I was absolutely certain that it would exceed 5,000. And that would put it as the third leading cause of death behind cancer and heart disease, overtaking accidents, all injuries, intentional and unintentional injuries. And I said, if anybody who says this isn't a big deal is not looking at the numbers, more people have died, and this is in November, than die from stroke, diabetes, suicide, homicide, car crashes, Alzheimer's, bronchitis, emphysema, influenza, pneumonia, and so on. And that was at 3,000. Well, we did surpass 5,000, not by year's end. It happened today, 6 days after the new year. So this was the prediction actually in September, that we would have about 4,600 deaths in Wisconsin by January 1st. And this model was an underestimate. And so you can see actually that the model said that the projection was to about 4,600, but if we began easing protection, it said it might be as high as 5,500. So we were somewhere this model was pretty good, generated back in late summer. Well, what does the current model say? Well, first of all, it says that it has several models, one of which is showing that rapid rollout of the vaccine will have as many as 8,000 deaths by the end of April. But if we have easing of social distancing and other control measures, we might reach 10,000 deaths, which would be absolutely phenomenal. About 48,000 people die each year. So this would mean that about 1 in 5 people would be dying from COVID-19 in a 12-month period. So absolutely. So the bottom line is, even this model is certainly very accurate for the next month or so. So I'm predicting that we'll exceed 7,000. I mean, even the best model is exceeding 7,000. So again, there's a lot more death and public health problems to come. Also, this is a wild card. We knew that these viruses mutate rapidly. In fact, they mutate every few days. And it's kind of scary. The mutations that have happened have not affected the spike protein. So the thought is that as long as they don't, the vaccines will be effective, because the vaccine is against that spike protein. But for some reason, this new variant that came discovered in the UK is more contagious. And you can see the epidemic, the spike in the UK. They've basically shut down the entire country, closed the borders. This virus is significantly more contagious. It's not more deadly, but with more people infected, more deaths will occur. So again, that's an important concept to understand, that by infecting more people, it will be more deadly, not for each case infected, but overall. So let me conclude with a couple of points. First, this COVID-19 pandemic is truly a major public health and economic crisis, especially for racial and ethnic minorities and people living in poverty, people working in essential services, really at the front line, including healthcare workers. It's been tremendously hard for people working on the front line of healthcare. Our social control measures that we thought would be relatively straightforward, they conflict with many people's personal freedom and certain political views. And I think this was an omen of things to come, that as this nation divides between people who understand the role of government and the role of public health responses, and others who disagree with any involvement of government in pretty much any process, let alone public health, we see this conflict, and it's obviously escalated in Washington, D.C. A vaccine, the good news is the vaccine is effective. These are incredibly safe and effective vaccines, and they will be effective, but they won't be effective in the long term. We need to really address these underlying systemic disparities in society and improve our public health system's capacity to respond. And sometimes I say if and when, but I think it's just when the next pandemic arrives, either when this virus mutates and becomes a different spike protein and is in need of a new and different novel vaccine, or when the next influenza or other virus strikes. So as long as we have these underlying problems in our society, tremendous social economic disparities, but also underfunded systems, we will continue to see problems with this pandemic and in times to come. So I'm going to stop sharing, and I probably went a little long, Tom. I apologize for that.
No, you're right at 7:55. That's great.
Okay, well, and I haven't been looking at the chat because I had my full screen PowerPoint. So I'd be happy to answer questions. All right. Yeah, go ahead.
We'll start with the chat to help prime the pump. Emma asked 2 questions, so I'll read both of them. Could H1N1 have been a pandemic? And could the U.S. have avoided the COVID pandemic if Obama's pandemic readiness group had been able to continue? Would they have addressed pandemics worldwide?
Well, so let me answer the second question first, because I think it's easier to answer. I think we would never know. I think it's unlikely. I mean, some of that is political positioning, posturing. I certainly think that we would have had a more cogent response in this country. I think we would have put off a lot of the uncertainty and maybe transmission and save some lives. So I think there's good evidence that, we were less prepared than we should have been. But this virus, it pokes around for weaknesses in the society, and it finds ways to get from person to person. So just as you shore up some aspect, and all of a sudden, you find people extending their family networks or traveling for holidays or getting back on an airplane. So I think the answer is, we don't know for sure, but I think we would have seen a more, less of a rapid rise. I'm not sure that we would have seen less people infected.
So, well, let me follow up on that then. Would you suggest to the new administration that they not restore such pandemic readiness teams, or do you think it's?
Well, again, I think the best approach was to delay transmission until such a time when we have an effective vaccine. And so the good news is that gamble paid off. I did not think we'd be putting vaccine in people's arms in 2020, which we were, and now well underway in 2021. That was both good science and good fortune that's worked. So the good news is, so looking back, I would agree that given that, yes, if we would have invested more in preparedness, I'm just answering the specific question of this one committee, if it's a pandemic readiness group. There are so many other working parts. If you have a public health system, from CDC down, that is not prepared, simply having a pandemic readiness committee might not have made a big difference.
And then back to the Emma's first question, could H1N1 have been a pandemic?
It certainly could have been. And the good fortune with our battle against influenza is that we have safe and effective vaccines. And so, and these circulate in different hemispheres, and we have to sort of guess what those numbers will be, the H number and the N number, and some are more contagious and more deadly than others. And so that's a bit of a guessing. Well, it's not so much guessing, but it's a predictive model where they predict what the predominant circulating types will be, and then and vaccinate. And we have a pretty good vaccination system, and people at risk of influenza tend to be vaccinated. So I think we were more prepared to confront influenza as a pandemic than we were with COVID-19.
Sandy Rotter asked in the chat, question, will those COVID-19 vaccinated folks lower their physical distancing? And then he has a series there, rebound effect, Jevons paradox, Kazum-Brooks postulate. I'm not sure what that means, but if you can address the physical distancing of vaccinated people and then any of those other things would be great.
Well, it's another concept is sort of compensatory risk behavior. So, you want to make kids safer, so you recommend that they put bike helmets on, and all of a sudden, the next thing you notice is they're racing down mountain bike trails going, 30 miles an hour, and mortality rates go up. So you give a vaccine, and now all of a sudden, the unanticipated consequence is it's time to party, and so people are taking risks. And vaccines aren't perfect. They have 95% efficacy. And so if we do, that was my take home point. So I think, Sandy, it's just pretty much every time we provide some kind of intervention that improves safety is people compensate by taking more risk. And I don't know those paradigms. Certainly those words make sense, rebound effect. The hope is that the vaccine is so effective and so well adopted that any compensatory risk behavior, that hopefully we can, once we are able to get transmission down and able to isolate cases, the few cases we see, then traditional public health intervention methods could work. And so you could go back to normal, like in New Zealand, the island that eradicated the virus. They're basically back to normal. That'll be a long time before we get there. But if you have high vaccination rates, then I think it'd be okay if people lower their physical distancing.
And then, Darius, do you want to ask your question, or I'm guessing Pat can read it if you want.
Sure, I'm reading it there. So it's a good question. I'm not as I said at the beginning, I'm not a vaccine or expert or a virologist.
Then Pat, can you read it for people?
Oh, sorry. Which part of the virus should be a target of a new vaccine? Any chance of an effective pan-coronavirus vaccine? So vaccines work because they are specific to the antigen expressed in the virus. And so there has been some work on the idea of a pan-influenza vaccine, the idea that one vaccine will protect you against all the subtypes. But I don't know of any discussion with the coronaviruses because I think these coronaviruses, the proteins that those antigens that they express, which are the handle that the vaccine grabs onto, are very specific. So I think we're probably going to be developing vaccines that are specific to each of the coronaviruses.
All right. Any other questions then in the chat, or anybody want to tune in? I've got a couple. I was surprised by what you said about the airborne, especially since your paper with the measles was talking about lingering for an hour, 2 hours. That's pretty impressive. So I wanted to reiterate, from your point of view, the airborne is not a major part of it compared to, or is it the aerosol?
Well, I think there are two questions. So I think when we look at outbreaks, we have most outbreaks, most cases are occurring with close contact.
Okay.
When you go and do contact tracing, you find people that were largely ignoring the public health recommendations, unmasked, closer than 6 feet for more than 15 minutes. But there are cases where people have been infected and they have been isolated. They've not been closer than 6 feet. And so you begin to wonder, could that have been an airborne spread? Or perhaps, a fomite. So, but the evidence isn't like measles, where a person came into a room and then, pretty much 70% of people in that room or in that building were infected. So okay. I think it can occur. I think there's some, particularly, as people are shouting or singing, where the virus is expelled over long distances, and the smaller that water droplet, the more likely it is to spread further.
Great. Emma asks, I understand that vaccinated people can be carriers. Will the vaccine make them less contagious than unvaccinated people?
I don't know the answer to that question. Generally, vaccines, if they don't prevent illness, they make the illness less serious, and I suspect that they make individuals who do get infected, despite being vaccinated, less contagious, but I don't know that for sure. I mean, the argument is that a vaccine is good even if it doesn't prevent illness, in that it reduces the seriousness of the illness. And probably, again, I'm just sort of guessing that it would probably make people, seriousness and contagiousness are probably closely linked.
I'd like to ask a speculative question. You mentioned how amazing it is, how much was learned so fast about the virus and its variants and its spread. We do a lot of comparison of this pandemic to the influenza 1918-19 pandemic. One of the things that at least when I was taking microbiology and teaching microbiology, was we learned so little. There are no Nobel Prizes in medicine or physiology or anything like that, no great advances in biology from the pandemic 101, 102, 103 years ago. Is that still how people look at it? It's to me, it's pretty impressive, the difference and how much we learned in the first 12 months of this compared to how much was not so much learned in the 12 months of the Spanish flu, the 1918, 1919.
Well, I think two thoughts. One is, yes, the scientific machinery were primed and ready to go, both on the basic science, the biology, the epidemiology. So I think, yes, we've learned a lot about this. I mean, it was sequenced before it became a pandemic. So what amazing biology. In fact, right here on this campus, I don't know if you saw the email that came from the president and CEO of WARF, John Wolfe, a colleague and a friend, was working with RNA viruses, and he actually wrote a science paper in 1990 showing how you could inject RNA into a cell, and that was the basic science that has allowed vaccines to be developed. So, so yes, that basic science is vastly improved. We would not have a vaccine today. I mean, I have to say, if John Wolfe hadn't done his basic science work, we wouldn't have a vaccine today. So we are a lot better prepared on the basic biology. The second part, my second answer is humans pretty much haven't changed since, the Spanish flu pandemic. You saw protests back then, you saw anti-government pushback, you saw differences in cultural responses. And we're seeing that today. I mean, maybe not to the extent, but there are a lot of similarities, and I don't think our sort of response to the problem is any more sophisticated than it was 103 years ago.
Great. And then Jim asks, estimates are that retargeting an mRNA vaccine for a mutated spike protein might only take about 6 weeks. What's your opinion on that estimate?
Well, I think you could probably create that vaccine pretty quickly. But then the question is, so now how do we get it into production? And now there are so many questions. Here's a good example. One of the things, before I get poked in the arm, I always like to think about not just, is my arm going to be sore and am I going to have an anaphylactic reaction? Those are things that you want. Anaphylaxis is very rare. It's occurred, but it's extremely uncommon, and it can be treated. And so, I have a few residents who work for me who have gotten vaccinated, and they have sore arms. Both of them have sore arms. But what the question is what about the long-term complications? And in order to study long-term complications, when you have a clinical trial, you have those vaccinated and those not. And you wait for years. And then you look at the long-term complications between those vaccinated and those not. But are we going to not vaccinate the people who raised their hand, volunteered for a clinical trial, got the placebo? Are we going to tell them?
Not by their own volition.
Yeah, by bad, well, we didn't know it'd be effective, but yeah, but they've got bad luck. They lost the coin flip. They got the placebo, but are they going to get vaccinated? If they all do, which I think makes sense, we're going to lose the ability to keep this trial looking at long-term complications because we will have an uncontrolled trial. So I think, if the spike protein mutates and this vaccine lowers from 95 to, 70 to 60, which sometimes, that is the influenza efficacy some years, we need better than that. If they come up with a new vaccine, we're going to have to, put it out in new trials. And that process, it's amazing that it was done in 6 months or less.
And then Dareth asks, what steps should we be taking to improve vaccine distribution?
I have no idea. That's a great question. Again, I'm not sort of at the control center of my colleagues at the state health department. I just wonder, they spend a lot of sleepless nights and incredibly stressful days trying to figure this out. We've designed a for-profit healthcare system that is independent, that's not, single payer, that, and it's the worst healthcare system you could design to do a vaccine campaign like this. We have a public health system that's stretched to the limits. and now asked to do this. So we're not prepared. And again, systems perform as they're designed to perform. And so we have competitive for-profit healthcare systems that aren't designed to work together, that don't align their workforce. And so this is a stress test for healthcare systems. It's a stress test for public health. What should we do better? I got a letter from my provider that said, be patient, don't call. So that's all the news that I got.
I'd rather be a patient and get called.
Right. So I'm over the age of 65. I'm in, should be in an age-related group, but I have a colleague in a southern state who's over 65, and he's already been vaccinated because they have a different priority system in the southern states. So,
well, a lot of us on Wednesday night at the lab here can remember getting the Salk and the Sabin. The Sabin was a live guy, and there's a story on about how 20,000 people were vaccinated in one day on a Sunday in Madison in 1964, and I'm left scratching my head about how it is that the distribution has been.
Well, I think there are two issues. One is there is a supply chain challenge, and so to do that massive campaign. But there's also a logistic challenge, and I just think we ought to admit we have both problems. We have a supply chain. There isn't enough vaccine, and the vaccine that is available, it's just really tough to get it out. It's just going to. So to me, that argues for patience. It argues for keeping safe if you can afford to, and just
But 3,541 Americans died of this thing yesterday.
Yeah. Yep.
And that it's just, every day that's lost is 3,000 people, 3,000 Americans, and much more than that worldwide. So,
Yep.
Other questions for Pat? And if you want to speak, can you? In the past, we've had people chime in. Tonight, so far, everybody's asked online. Is that because I've got people muted, or Bea, can you unmute? Or, well, you're a co-host, so you can probably unmute.
Yeah, I think people can unmute if they click their microphone.
Okay, good.
Yes, we can unmute.
All right. How's it going, Dareth?
Just fine.
Good.
I'm impatient. I want my shot.
Yeah.
Did you get the letter?
I got the same letter. Be patient. Don't call.
All right. That's what I'm doing.
Well, I got to just maybe come here.
Hello, look at this.
Our youngest speaker.
That is cool.
This is my grandson, Ronan.
Hello, Ronan.
Hi, Ronan.
Who are all those people?
Hi.
Oh,
look, it's a Zoom wave. We're not even saying goodbye.
He just turned 1, and I just hope, again, the context of, and he's also very busy and on to other things now.
Did you see that, Dareth? I think there's a salique on his little neck thing. Those types of seed pods.
Oh, is that? Yeah. So
Dareth's a horticulturalist.
We need to figure this out, both as the biology, but also society, and figure out how to do a better job the next time. Be patient, stay safe, and hopefully our turn will come for the vaccine, and then just get back to work to try and be better prepared the next time.
How can we improve our public health department's function? What should we be changing going forward?
Oh, just better funding. I mean, when I worked at CDC, I went to a health department in South Carolina, and I was just struck that there were no state dollars. It was all federally funded. And then I came back to Madison thinking, well, we're going to have a great funding for our health department, and no better, largely federally funded. We're sort of 50th in the nation in per capita funding in public health in our state. It's just an embarrassment. And so you just have to provide the funding necessary to have the infrastructure. And sometimes you have to, I heard President Trump say, I don't want to pay people to sit around when nothing's happening. Imagine if you took that approach with a fire department. It's like, that's why he let go everybody, because they were sitting around doing nothing, waiting preparedness means that you're prepared. You're not busy. So
You're
he
training.
wasn't busy. And so we just need to be prepared, and we have to make the investments and trust that our scientists know that this stuff is coming, and they knew that this was coming. And, you know, don't make the same mistake twice.
Ronan's coming.
More specific, a more
I
more
do have,
specific question.
yeah, I have another question. With all the different vaccines, what is the big difference between the vaccines? Or is it we all going to be as as immune as everyone else? Or
They seem to have the same level of efficacy. So I think one of the big differences is the supply chain, that the Pfizer has to be kept really, really cold. So that's a big difference. But other than that, I haven't heard any physicians that I know who are sort of waiting for the Moderna or the Pfizer. They have the same sort of basic function. They mimic the production of the spike protein, and then your body attacks the vaccine produced antigen. Sorry, yes, your own cells produced antigen. So it's a brilliant idea to get your own cell to produce the antigen, and then your own body to develop the antibody. That antigen is not a virus; it's just produced by the messenger RNA that's gone into your cells. So absolutely brilliant. And so, you're not getting a virus injected in your arm. You're getting something that's going to tell your cell to build, to produce an antigen, which your immune system will then develop antibodies. And I think they're all fundamentally, and again, but I'm not an expert in virology. There could be, some fundamental differences.
And then Sandy, you had a question?
Yeah, a more specific question about a dental hygienist that parties it up before I have my mouth wide open getting my teeth cleaned.
That did what, Sandy?
Well, if a dental hygienist gets the vaccine and doesn't follow the same protocol, it still can be a viral carrier. And then,
So that's a good point. I mean, I think this is going to be hard because, let's say there's 100 people on this in this call, and we get the vaccine, and 5 of us, don't. It's effective for 95 and not 5. Well, are you willing to have 1 out of 20 dental hygienists who are contagious? So what's our level of tolerance? I'm 95% sure that my doctor doesn't have COVID, but I want to be 100%. So I think we're going to see a difference in long-standing differences in infection control, and maybe even in people's tolerance to be exposed to other folks. And my son said he went to Japan a few years ago, was struck, 20-30% of the people walked around with masks all the time, mostly because they felt that they had an illness and they wanted to protect the health of others. Will we see that in the future? Because even if you're vaccinated, if you get an infection, it could be COVID. And so I don't know the answer to that question.
well, I guess is even with the worst behavior, I'm still better off with a hygienist getting the vaccine.
Yes, absolutely. Absolutely, but you'd be even better off if that hygienist maintains infection control practices and is vaccinated. That's the best. You don't want them sort of taking the mask off and not washing their hands because I've got the vaccine. And I think that's true for everybody. Is you want to, I hope there's going to be continued hand washing. I hope that people aren't going to be sneezing into their hands and shaking hands. I'm never going to shake another hand. I'm done shaking hands. I stopped shaking hands in February. I went to a meeting with doctors in February, and it was probably 50, 60 doctors, and I held up my elbow, and they said, they went COVID. And I went, yes, COVID. Shaking hands is the most ridiculous thing we do. We handle our face, we cough into our hand, and then we think we're, making a good gesture to shake somebody's hand. So I think things will differ. I think you're going to see new ways of greeting people.
So at the American Health Association, are you going to have a similar video tweet of the escalator versus the elbow shaking?
Yeah, I think, but mark my words, I think there'll be elbow greetings for a long time.
Well, we saw that with the in 2010, I think I went to a thing at AAAS where everybody was elbow bopping.
Yep.
Must have been the H1N1 2009, 2010. Any other questions?
Yeah, sorry, I have so many questions, but
Right. It's about.
yeah, well, I was wondering about treatments because I think maybe that's the other way that, you know, this will be dealt with. And I'm wondering what you think the prognosis is. Will we be able to find some?
I don't think I wouldn't put my, if I were a betting man or investing, in companies, I would put it in prevention and vaccines and, state of the art masks, and treatment is very tough. Viruses are tough to treat. They're not bacteria. We don't have antibiotics. We have antivirals, but this virus does a lot of damage before it causes symptoms. And so I think it's going to be hard. I mean, there have been some modest improvements in survival, but I think some of the claims that there's a miracle drug are, certainly not founded. So I think the best medicine is prevention.
And that's why you're in preventive medicine.
Yeah, I'm biased. I'll admit I have a professional bias.
Any other questions? Well, we gotta send Ronan some.
I see Terry has a question.
Oh, okay. Sorry.
Thank you very much for your talk this evening. It was good. I happen to be in Florida, and this is a question regarding the role of public health. Is there a way to fairly register people for vaccinations? Is that in the realm of public health? Down here, they seem to have rather chaotic areas, and each county runs their own registration process. And some counties were initially first come, first serve, and there were long lines down here waiting. They waited in lines for 12 hours, some sleeping overnight. Well, here they are, more than 6 feet together, less than 6 feet. And other counties are going with first come, first serve, however you know how to register. And most of it is online, and some people don't know how to do that. So is this in the realm of public health to begin that registration process so everyone can fairly and at leisure get the vaccination? How does that work?
Well, Terry, long ago, we decided to get public health out of the healthcare business. And that happened maybe 20, 30 years ago. And we put that responsibility into the healthcare system. So, so we don't really have those systems really in place anymore. I'm glad I live in the U.S. I love the freedom and the independence. I love a decentralized government system. Public health is administered locally. But I admire some of these countries with very strong central governments when it comes to getting stuff done. They just get it done. You get a number, when you're born. They call you in when it's time for your shot. It's very regimented, it's very ordered. And that's the price we're paying for, our decentralized sort of, private sector for-profit system, is that it's nobody's responsibility. And so I think unfortunately, it's going to be those who, make the loudest noise, or get in line earliest. They're going to get it first. It's not, we are not prepared for this. And yes, I mean, back in the day, at school, we lined up at school and got vaccinated. But that's a complicated system too. That requires, those were armies of people that went out and did that. And, we'd have to sort of mobilize, and maybe the National Guard, maybe it is a National Guard. I get the National Guard to come and just go community by community. But we don't have the supply.
Doing
That's
the
the issue right now. We just
testing.
don't have the supply.
Wow.
But once we get the supply, it looks like we're going to have a whole bunch of just finished their residencies and potentially just finished their medical school people who are, because of the nature of our for-profit medical care system, not finding jobs this year. Why not utilize those as some of that army of people to go out and help vaccinate when we get more supply?
Well, I agree, and this is going to be the challenge, and we're a country where we like to innovate with small models of excellence and try and spread that innovation out. So I think the bottom line is there is no blueprint, and I think having a consistent, I think it'll be really nice to have a consistent voice from Washington and a consistent, credible voice from CDC. I think that will, what a breath of fresh air that will be. Hopefully Tony Fauci lives on and continues to be active. And we get experts who are truly experts and not politicians. So that will help. I mean, I think there are systems that can be replicated, and so I think it's going to get better in about 2 weeks. I think we're going to start seeing some more reasoned, centrally directed recommendations that then states and local communities can follow.
Are we letting perfect get in the way of good enough?
Well, there's been a debate that, we should just be trying to do good enough, try and get one vaccine and as many people, one shot and as many people armed as we can. That's a different approach as opposed to being perfect and getting, 95% in the high risk group. I don't think we know the answer to that question. There is debate that, let's just get it good enough. Let's just get as many people one shot and get everybody up to 60% efficacy. And maybe that would do a lot more good. I don't know the answer to that.
I wasn't thinking in terms of giving a lot of people one shot rather than two. I was thinking in terms of how we're organizing giving shots at all. It seems to me we're trying to reinvent a wheel that is more complicated than it needs to be.
Well, I think we took the car apart, 30 years ago. By disassembling much public health infrastructure. Public hospitals have been closed. Public health departments that used to provide clinical services and actually immunization services. We've dismantled all that and put it back into the private sector. And so you can't rebuild the wheel. The car's in pieces. It's going to take a lot longer to put that car back together than it is to sort of cobble together whatever ways we can get it done. As Terry said, get in line.
Thanks for showing the slide of Virginia Mason Hospital. That's where I served my surgical residency and fellowship.
Oh, yeah. So
a lot of memories. Thank you.
Well, certainly. I was a VM. I did a transitional year. I was just going to do my internship and go overseas and be an international doc. And I made some very good friends out there to continue to go out and visit. And Seattle's a wonderful town, but Madison's pretty nice too.
Jerry, what kind of surgeon are you?
Well, I'm retired now.
That's the best kind.
I did broad range of general and vascular surgery, some oncology as well. So really a true general surgeon for my training for Virginia Mason.
Was Dr. Beebe, was it a Dr. Beebe? He did vascular surgery.
Yes. I was his first, what you'd call senior resident that managed his service when he joined the clinic at that time. So I got to work with him one-on-one.
I had to do a month of vascular surgery, and I would say that month is the one life experience that made me go into public health. He dismissed me from the operating room because of my incompetence and had me just go to the library to look up evidence-based approaches, which, by the way, he was doing carotid endarterectomies, which years later, the evidence wasn't really so strong to support some of the things they were trying to do. So But yes, that was, what I learned is the fortunate thing in medicine is there are people with different specialty expertise, and mine was not surgery.
Very good. All right, it's 8:30. Any other last questions? If not, thank you again, Pat, for pinch hitting. Splendid job over the fence. Way to go.
Thank you.
It was great. Thank you.
Yes.
Thank
And
you,
let me know whenever you want to come back and do a retrospective on Thermus aquaticus.
No, I feel I'm really, again, I am sort of an inch deep in my knowledge of COVID, and I wouldn't even be measured sort of in millimeters on my knowledge of basic science. And
You have to have some good Kodachrome slides of Yellowstone, though.
yeah, but I do actually. And my girlfriend came out and visited me, and now she's my wife and the grandmother of my grandson. So it was a great summer.
Great. Well, tell Ronan the royalty checks will be coming in.
Will do. Thanks for
All right.
organizing, Tom, and nice to see everybody, and hope to see you again.
Excellent. Thank you
Stay
again.
safe, everybody. Just don't, as someone said, don't mess it up now. Let's get the vaccine on board, and then figure out how to fix the system and society later. And I just want to give a shout out. I see two people I went to kindergarten and grade school at Shorewood Hills. Not just Sandy Rotter, but I see Paul Boutwell's name there. And neighbors growing up in the Shorewood Hills and have been lifelong friends. Good to see you virtually.
Well, Sandy's emails to you that he includes me on that encouraged me to give you that call. So
Great.
appreciate
Thanks,
it.
everybody.
All right. Thanks, Sandy. Thank you, Pat. And have a good night, everybody.
Okay.
Stay well.